Good evening. Thanks for joining us tonight. Looks like we have a crowd from all parts of the world. Thank you for taking time away from your practice, from your family, from your friends. It's always nice to see. We have people here from Qatar, from Egypt, Mexico, the UK, Kuwait, Australia, Israel, so many different countries around the world. It's amazing how far we can reach using the World Wide Web. So thank you for being here. My email address below on the right-hand corner, Dr. Ganz at drgans.com. Please take a note if you'd like to contact me in the future. I always like to start out with this one basic philosophy, that there is a danger when we are bound by two-dimensional concepts. And clearly today we live in a three-dimensional world. And so keeping that in mind, let's go through a couple of concepts. My last webinar revolved around the concept of brain-guided surgery, which came from an ad that I had seen on the internet about brain-guided low-cost implant surgery for every practice. And of course, I hope that many of you have taken some of that advice that I've been talking about for the last 3 years approximately since this came out. Some of the concepts we talked about in the course that was advertised was brain-guided versus cone beam-guided surgery, which works better. We'll let us all evaluate that concept a little bit later. Why you never need expensive technology to get started doing implants. And of course, say no to guided surgery. So that was the advertised program. And that's what we talked about in the last webinar. We're going to come back to some of those topics today because obviously when we look at some of the incredible imaging technology, cross-sectional images, axial images, three-dimensional reconstructive images, we get so much information for our patients to be able to determine a variety of different treatment options, and then we can choose the best one for that patient. Many years ago, I came up with this concept called prosthetic gymnastics. Now, would you call this brain-guided? I'm not sure. Take a look at some of these images. These are actual cases that I got from social media, and these are from different laboratories. Look at the positioning. You can't make this up. These are angles that are difficult to restore. And so the concept of prosthetic gymnastics is that when the laboratory gets a case like that, where the implant is located in a bad position, and you want to be able to then restore it, somehow the laboratory has to create the link between that implant and the restoration, and that is prosthetic gymnastics. And so when we evaluate for these types of cases, when we're dealing with multiple implants, as you can see here with screw access holes coming out all over the place, we have to be able to plan properly. So take a look at this case, which also I got from social media. Is this restorable? If this patient came into your office and someone else had placed these implants, would you be able to restore this case? Look at the vertical dimension of occlusion, look at the soft tissue, look at the healing collars that are placed there. How would you determine whether or not you could restore this case? What are the steps that you will go through? We'll come back to this a little bit later. So brain-guided, here's another case. I touched upon this in the last webinar, where as you can see, this represents what was supposed to have been a bilateral sinus augmentation. You can see the green arrow illustrates a septum in the maxillary sinus on the left side, and you can see in the lower arch there are 5 remaining implants, but they're barely in the bone. And so as we start to analyze these types of cases and come up with a treatment plan, what exactly are we going to do for these patients? And here you can see the pre-existing condition. These are locator attachments on these 4 implants in the anterior region that are obviously hopeless and failing. So what are we supposed to do? How are we supposed to treat some of these ailing and failing implants that we can see on a regular basis as our patients get older, as our patients age naturally? Their prosthesis and their implants are going to go through mechanical stress over the years, and we will have to deal with our aging population. I personally have implants that have been in place for more than 25 years on many, many cases, many patients, and therefore we have to, in many ways, be married to these patients over the many years that we will be treating them. So this is what I call selective transparency, where we're visualizing through the different structures based upon their density. In the maxillary arch, there was supposed to be bone. There is no bone. As you can see, the large cavities, and if you're not used to seeing these images, this is a 3D volumetric reconstructed view. There was no preoperative cone beam CT scan in this case, and so this was done freehand. There was a flapless surgery for the mandible. There was no evidence of any bone augmentation in the maxillary sinus, and of course, the patient was not happy. And so as we start to evaluate this, utilizing our expensive technology, and of course, you don't have to own this technology. I'm saying that sarcastically because we have the ability to send our patients for scans at a neighboring facility. We have vans in the U.S. that will come to your office with a machine and help scan your patient. And then we also have third-party companies that will help you evaluate, and so you don't necessarily have to own the software. Of course, there are softwares available that you can download for free today, such as Blue Sky Plan. If we take a look at this image, it's showing that we have 5 implants, 4 of them in the anterior symphysis area, and look at the difference between the right side and the left side of the mental foramen. There is, without question, a difference in that location. And of course, patients are not symmetrical. And so this asymmetry can lead us down the wrong path, especially if we want to reduce the bone to widen the ridge to perhaps place new implants in this area. But how do we determine whether we can do that? So after this patient came to me and we evaluated this particular patient, we were able to look at the sinus where there was no bone and then fill it with bone. And this is what a post-sinus augmentation should look like. And we can go in, we can visualize and make a measure. We have 18.3 millimeters of bone where we had 0 before in that pneumatized sinus. And very important to be able to assess the distance between the medial and lateral walls of the sinus so that we can fill in these areas and get the best vascular supply for this graft. Once the graft has matured, of course, over the particular months that you want to wait for the maturation, we want to be able to then plan for our implants. And of course, at that point, we're going to use our interactive treatment plan software. And the idea is to be able to plan the position of the implants so they're going to be surrounded with the most volume of bone. That is our goal for this type of treatment. And so we're going to skip over to the mandible for this particular example, showing the implant simulation. And you notice that these implants are parallel. They're not tilted. Could you do tilted implants? Certainly. I also want you to pay attention to where the apex of the existing implants are in a blue kind of color. And you can see the length of the implants that we're simulating here that go way beyond the apex of those other implants. And look at the way that the bone topography has tremendous variation here. And so we want to be able to simulate the placement of the implants using our selective transparency. And here's a kind of a golden rule. If you're going to plan for bone reduction, always plan the position of your implants first. Don't plan the bone reduction and then come back and position the implants. And you'll notice that there's yellow projections, and those yellow projections are there for a reason so that you can visualize where these implants are emerging through the restoration. Now, back in 2002, I came up with the concept of the bone reduction template, which was first published in 2006. And so we have the ability to create a bone reduction guide, but it's not necessary for every single case that we do. If you take a look at the cross-sectional images, and here we'll blow it up a little bit better, you can visualize here in the lingual concavity, the anterior symphysis is not the ideal and perfect bone for positioning implants every time. Every patient is different, and that's the reality of anatomy for every patient. So we have to evaluate the density of the bone. We want to be able to position the implant. Now remember, this is positioning the implant after other implants had already been placed. And you can see on this particular slide or a cross-sectional image that we have the white opacity of the existing implant, and it's barely in bone, and you can see the apex of this implant trying to gain bicortical stabilization at the apex. And so we have the ability to be able to assess the variations in bone to avoid complications. And you can see the invagination here of the lingual aspect, where there is a big concavity which could easily be perforated and cause a sublingual hematoma. So we have to evaluate every image that we see for our patients. Using interactive treatment planning software, we have to be able to evaluate the mental nerves using selective transparency, advanced segmentation features, and in this case, we're going to try to parallel the implants. So here again is the preoperative condition of these failing implants, and we're going to go and determine how we're going to remove them. Now, because these implants were almost not in bone at all, it wasn't a difficult task to try to remove them. The gold pieces that you see on top, those are locator attachments. The locator attachments are almost as long as the implants. So here we are, we've removed the locator attachments, and we're going to go in and then we're going to remove each one of these implants. And in this case, we're going to use some brand new instrumentation. These are the Frings forceps, available also from IBS, which has a wonderful, wonderful thread design and tremendous grip. It has a spring in the handles to aid in the comfort in your hand and control of whatever type of extraction, or in this case, removing implants, under tremendous control of this particular instrument. Some of the best instruments that we have tried in our practice. And so once all of the implants are removed, we're going to do what I call template-assisted surgery. Template-assisted surgery is that we're going to create, in this case, a resin 3D printed template. We are going to use sleeves, and this happens to be the Formlab 2 printer, which I have in the office. And we are going to use the sleeves to drill to the proper depth and the trajectory, sleeve by sleeve or site by site. And you can see that we are able to get irrigation, and we are able to have depth control and go through the actual drilling process for sequential drilling. And then, because I term this template assisted, we are not going to place the implant through the template. We are going to place the implant freehand. And so there is some potential for movement or variation of angle or trajectory when you're placing the implant freehand. And so you want to make sure that you have total control, and you notice my finger is on top of the drill itself as it is guiding the implant in, and then we're going to torque the implant into place. Now, if we're going to plan to do an immediate restoration, which we did for this particular case, is it the torque itself that's going to give you the confidence to load this case, or is something else have to happen? Is there another device that we want to use? So here's the immediate post-op radiograph. We did not take out the implant in the posterior right, and that was specifically for the patient requested that. And we are going to measure using resonance frequency analysis, implant stability quotient, a value that tells us if the implant is stable in the bone. And therefore, when we have these values, it gives us a level of confidence and a medical legal entry into the patient's chart that, in fact, we have implants that are sufficiently stable if we choose to load them, which is what we did for this case. And so this is what we started with. We used the titanium sleeve and screws, and then we will load this case with a conversion prosthesis from the patient. So we are using our brains, and our brains are going to be used in conjunction with some of the technology that is, of course, computer assisted. And so technology is important, and this is really the basis and the foundation for proper diagnosis and treatment planning. So let's go back to the case that I showed you earlier. So here you see these 3 implants, and I asked you, could you restore this case? Nice keratinized tissue. We have what appears to be a nice width of ridge. But how do you know? You tap on these implants to see if there's a nice ping sound to tell you whether you can restore them? Or are you going to take an ISQ measurement and determine, in fact, that this implant on the right-hand side is not even in the bone? We call that air integration, not osseointegration. So we want to avoid air integration. And so if you went and you tried to take an impression of this implant, I think you probably would have had a problem. Again, this was from social media. Now let's go through a couple of determining factors here. Here you see a tooth within the alveolus. This is the reality of anatomy for this patient. There's almost no bone surrounding a natural tooth. This is normal in many cases. It may not be normal in your eyes right now, but when you look at hundreds and thousands of scans, you realize that this actually is the relationship between the alveolus and the tooth in many, many cases. And so we have to have a plan of where this implant is going to be placed based upon the type of restoration that we're going to replace it with that's going to be supported by an implant. So in this case, if we wanted to do a cement retained restoration, we can see that yellow projection is going to give us an angle through the envelope of the tooth, and then we have to determine whether or not we have to bone graft to give us the volume, not only to stabilize the implant, but to support the soft tissue as well. And so it goes to being the engineer and the architect of the oral cavity, which of course brings us to the triangular bone concept, which identifies this potential receptor site or the zone of available bone for placing an implant. So this would be a cement retained restoration concept for us to be able to review. Here's another situation. Again, here's the tooth, there's the alveolus. Let's place an implant in the most available bone, but what if we wanted to do this as a screw retained restoration? We're still within the triangular bone, but now we need to move the implant. We need to move the apex of that implant towards the buccal, and we need to be able to change the trajectory so that it comes out, and you see the yellow trajectory, so that we can have a screw access hole. But you'll notice that the threads are into the buccal cortical plate. So perhaps we need to move that implant slightly to the palatal. Still we're in that zone of the triangular bone, and now we have to worry if the threads on the palatal aspect may cause an issue. So this would be for a screw retained design. And this is what we need to be able to appreciate, because when our laboratories help design the restorations, we want to be able to have a result that looks like a tooth sitting on its root. And here you see the beautiful emergence profile, but is this screw retained or is this a cement retained with a CAD/CAM restoration? We have to think about what is the outcome before we touch the scalpel to the patient. And as you can see, if we want to have a screw retained restoration, it'd be nice if that screw access hole came out right within the envelope of the tooth. So that is the goal. Patients are coming to us not for implants, they're coming to us because they want teeth. And so when we look, side by side, it's basically very hopefully indiscernible which is the implant, which is the natural tooth. And in this case, this was a screw retained restoration. Nice emergence profile, good maintenance of the crestal bone, and the implant goes beyond the apex of the adjacent teeth. So this is part of the goal that we want to achieve. So as we start to think about these concepts, of course, we've been able to try to advance the technology and deliver some education through our educational portal, which is Advanced Implant Education, and myself, Dr. Isaac Towell, and all of our faculty welcome you to join us on some of our trips. This happens to be in Puebla, Mexico, and you can see in the background a live volcano. Hopefully it will not erupt while we're there. And of course, we can't do it without some of our wonderful colleagues, some of them from around the world. Ashraf Shuhei comes all the way from Tunisia to join us on occasion, and there's Isaac Towell to the left of the picture. I'm also one of the editors of CAD/CAM International Magazine and on Cone Beam CT magazine from Dental Tribune International. You can download many of the articles that I may allude to and others that I may not have time to allude to by going online to Dental Tribune International and look up their e-papers. And these are readily available online, especially the back issues. So, philosophy. My basic philosophy, which you might want to think about, there are two technologies that are essential for implant placement and restoration. Placement and restoration, meaning surgical and restorative, and that's Cone Beam CT, that's the basic foundation, and then RFA ISQ, implant stability quotient, resonance frequency analysis. And so when we start to think about Cone Beam CT and the different fields of view, you know, I was rummaging through my office. I found one of the, just to give you an idea how long we've been doing this, this is not something that we just started with 3 or 4 or 5 years ago. Here's one of the original discs, if you can remember what a floppy disk looked like, from 1994, version 1.1, Simplant for Windows. 1994. Think about that for a minute. So the question is, do you ISQ? And the answer should be yes, because the objective values that we get from implant stability quotients give us that confidence that we can load an implant. Of course, imaging technologies are changing, allowing us to be able to do wonderful things, but there is a basic concept that we have to have as a foundation and a philosophy, and that is that the tooth position should always guide implant placement. We should determine screw retained or cementable before we touch the scalpel to the patient. We should know which abutments that we're going to use, and obviously our goal is to deliver the best function and aesthetics for our patients for every case. So we divide the world of Cone Beam CT diagnosis and treatment planning and guided surgery into 3 distinct different methods. The first one is diagnostic freehand, template assisted, and then full template guidance, and this can be found in our textbook, The Ganz Rinaldi Classification of Guided Implant Surgical Protocols, which is available now also in Chinese. I'm not sure that we have anyone from China here on the webinar tonight, but if you're there, I hope it translates well, because I can't read Chinese. Diagnostic freehand. Basically, we're going to take our measurements, we're going to visualize, and then we're going to do things freehand. Template assisted, I showed you on the first case, is when we create a template. And we're going to control the trajectory and the depth, but we're not going to place the implants through the template. Full template guidance is where we will place an implant through the template after we've completed the osteotomies and the depth control. This happens to be the Chrome Guide concept, and we'll talk a little bit more about that later. And of course, in order to do full template guidance, you need to connect to the implant with a special carrier that allows you to then go to each one of these cylinders to position the implant properly with your handpiece. And then we can torque it with our torque driver, and you can see that we can measure the torque as it goes in, but insertion torque by itself is not a measure of implant stability. Now, we're of course talking about the digital universe, and I'm very proud to be a member in the United States of the Digital Dentistry Society and the worldwide organization, and we have some wonderful, wonderful colleagues that are members of this growing organization around the world, and I hope that some of you will look at the website and be able to perhaps join us in our quest to be able to deliver the best education in digital dentistry. We have access to the BMC Oral Health, one of the best journals to be able to publish many of the different wonderful articles that are coming out from all of these different wonderful members, and I'm proud to be one of the board members from the United States along with these wonderful clinicians. So, digital technologies, we have a consensus conference that's going to be taking place in about 2 weeks in Marrakesh. Here's an article from Canada. My dear friend, Dr. Gilbert Tremblay, and some of the wonderful cases and research that he's done over the many years. We've been able to collaborate on this article, which was recently published on 2 different protocols, which gives you kind of the evolution of what we do with guided surgery, as you can see here, with a different type of template, that also relates the relationship between the restoration and the bone itself. And so we need to be able to not just have a guided surgery in terms of the placement, but it has to relate to the actual restoration. And so here you see also a resin, a resin fabricated through 3D printed template, as well as you can see the prosthesis will sit directly onto that template in a scallop guide position to seat the prosthesis into place, so that orients the restoration directly on top of the implants that are just placed. This was also recently published in the last edition of CAD/CAM International Magazine, the Cone Beam CT supplement, and we're very proud of that international exposure. So again, you can go online and you can download some of these articles. So basically what we're talking about is a tremendous amount of power to be able to diagnose, to be able to treatment plan, to be able to then communicate, and be able to then execute the plan. So it's pretty simple once we have an understanding of what we can do with our digital tools. Now at the IDS thing in 2017, the biggest thing that we were talking about and we're looking at besides 3D printers was intraoral scanners, and there's so many that are on the market today. But the concept is, of course, to digitize the information from the patient's mouth to the computer so that we can, in fact, create the restorations and create the plans to be able to merge the different technologies together. Now, one interesting device that I will share with you, when we're trying to scan intraorally, it's sometimes difficult to retract, and we need, a non-reflective retractive instrument. And this is one that's just on the market by this company called Armor Dental, and it's called ScanMate. And I just thought I would share this. I have no financial interest whatsoever, but it's just it just hit the market, and it's a wonderful, wonderful device to be able to retract and in a non-reflective way. And here's some pictures courtesy of my dear friend, Dr. Richard Martin. So it reduces the artifacts, and we don't have to, use other devices in order to get the lip out of the way. So that's called ScanMate. You can look for that in the future. Here's an article that we wrote back in 2012 using, of course, Cone Beam CT combined with our intraoral scanning technologies. So we've been doing this for a long time, and of course, the idea is to utilize our digital tools properly and to be educated on the digital tools as best we can. Here's a great article by Joseph Kahn from 2011 talking about these cross-sectional images in the anterior maxillary arch and the position of the roots, the natural tooth roots within the alveolar housing. And he divided it into 4 different classifications. This happens to be classification 1, which is about 80% of the time, and you can see that we can visualize this triangle of bone concept to be able to position the implant more towards a palatal direction because that's where the bone is. You can see that there's almost no bone on the facial surface or the buccal surface of these natural teeth. So when we talk about implant stability, we need to be able to do an immediate extraction, but we also have to go beyond the apex to stabilize the implant, and this is where the triangular bone concept becomes very important for us as well. We have to be very careful when we're drilling in that palatal direction so that we can, in fact, avoid perforating through the facial plate. And of course, that also brings up the concept of maybe maintaining part of the root of the tooth, whether it's partial extraction therapy or what we like to call this a root membrane concept, because it's basically keeping the periodontal ligament in place, and that therefore allowing us to be able to save that fragile bone on the buccal or the facial part of the tooth. And that, especially in the aesthetic zone, becomes very important. So when we look at the triangular bone concept, we want to be able to position the implant, and we also want to avoid hitting that root fragment when we're doing partial extraction therapy. So again, in coordination and collaboration with 2 wonderful clinicians, Dr. Isaac Towell and Miltiades Mitzias from Athens, Greece, we're able to visualize a case like this, where we're going to go in, we're going to plan to section the root of a tooth similar to this. And again, You can see the difference between a cement retained and a screw retained position. And here is the root membrane concept based upon restorative planning. And so we want to bisect that triangle when we can to surround the implant with the most volume of bone. So again, here is that in the red outline, we can see the potential where the root fragment is. We don't want to touch that root fragment if we can avoid it, because we don't want to damage it in any way or loosen it. So there are many articles and many technologies that have been advanced over the years, from Simpress's articles through Howie Gluckman and many others, Marcus Hertzler, over the years, that have been proponents of doing a partial extraction therapy, and Howie Gluckman in South Africa. So this root membrane concept allows us to be able to maintain the buccal or the facial part of that root, as you can see here with the bicuspid tooth, and this is now being sectioned. Megagen recently came out with a root membrane kit, and that root membrane kit gives you a step-by-step protocol for being able to use some of these instruments to separate the root, to be able to then manage that root membrane, because we have to trim it. We have to make room for the implant. We have to make room for the restorative componentry. And then, of course, we have to drill to avoid hitting that root fragment. So the root membrane kit allows us to be able to do this. And of course, if we want to avoid the root fragment, we are going to place the implant within the triangular bone concept. So here you see that C-shaped or moon-shaped type of root fragment. The implant is not touching that. We're going to then place a healing collar with a poncho technique with a PRF membrane. You can see the healing collar, and then we'll allow that to heal, utilizing sutures, of course, to hold everything in place. So again, diagnosis is very, very important to being able to achieve success. And this is not a case where we're going to do immediate load. However, we could do immediate load even when we're doing a socket shield root membrane type of procedure. We'll investigate that as well, hopefully in the few minutes that we have. So here's a little video of the root membrane concept. As you can see here, this is the root membrane kit. This is one of the cases, one of the first cases that we did in our center in Tijuana, and we were able to introduce this with the surgical demonstration that was done during one of our live surgery courses. And here's some of the people that helped invent this root membrane kit from our international colleagues. So first we're going to look at sectioning the roots. We're going to utilize some of the instrumentation, which is well marked, so we can control the angulation and control the depth. And by the way, we can also do this in a guided approach as well, although we don't necessarily have all of the time in the world to discuss that today. So what we really want to do is we want to be able to carefully separate this palatal aspect of the root, and then you can see that the fragment then needs to be trimmed and needs to be modified in order to receive the implant without touching that root fragment. So here's the root fragment that's removed, and then we have to go back and we have to trim that aspect of the remaining root fragment. And obviously it would be very helpful if there is no movement of that root fragment. If that fragment is moving, then it should be removed and not utilized in that way. So here we are using one of the diamond instruments to go in and to modify the surface of that root membrane. We're going to go in utilizing the different instrumentation, of course, that is seen in the membrane kit, and basically sculpt the inside of this root to be able to have and maintain the very fragile buccal plate of bone without by also leaving enough room to place the implant in the palatal aspect. And so here this wonderful diamond tipped instrument is utilized to be able to bevel that area, as you can see here, and it works really, really well to be able to sculpt out the inner aspect of this root to make room for the eventual placement of the implant. So having the proper instrumentation is essential to improve on to be able to take your diagnostic planning and be able to execute that. So here you see the implant is going into place, and we're going to then, of course, measure the stability of this implant by using our implant stability quotient, resonance frequency analysis, and come up with an ISQ value. So it's very, very important that we start out with a proper diagnosis so that we know what we can do. And here you see an ISQ value, I believe, of 70 with the SmartPeg for this particular implant, which happens to be an AnyRidge implant. And we can visualize the stability on the Mega ISQ device that you see here. And so again, we are living in a time where these digital tools are extremely important, and it helps us to be able to determine whether or not we can load these implants or not. And so here is a final picture of what that should look like. So as we start to be able to develop some of our skills, it's important to be able to know what it is that we can do. And this was published in Dentistry Today in 2017. And although they put my picture on the cover, I think Dr. Sia is much more attractive than I was, and so she definitely deserved the cover. So as we can see here, we published an article also in 2017, the first human histological evidence after 5 years in function. And this is very, very exciting, certainly proof of principle beyond with the first human histology. And so many, many more articles. A 10-year article just recently was presented as well. And the conclusions here supports the assertion that the root membrane technique is effective in preventing bone resorption of the buccal bone plate of the anterior maxilla after 5 years of placement. So this is certainly something that we should be considering. Utilizing a program called R2Gate, we're able to look at some of the cross-sectional axial images for each one of our patients to be able to have that proper diagnosis, and we can visualize where bone loss may be, we can visualize where implants can be placed, and in fact we can visualize and interact with these images so that we can have an interactive experience and manipulate the images so we can visualize them in all different views. This becomes absolutely important whether we're using this software or any other software. It's just a matter of being able to understand all of the different views, because not one single view is going to be effective in obtaining the best diagnosis and treatment planning for your patient. And so we need to be able to visualize, for instance, the path, of course, of the inferior alveolar nerve. We want to be able to utilize color when it's appropriate. We want to be able to make sure that we understand the levels of density, the thicknesses of the cortical plates, and be able to then pick and choose the implant diameter and lengths that are appropriate for each site. And this is really the basic foundation of what proper diagnosis and treatment planning is all about. When you get to a point where you're starting to look at positioning of implants, and especially when we're looking at, let's say, avoiding the maxillary sinus by placing a tilted implant in the posterior maxilla, we of course have to know that the abutments that we're going to be utilize, of course, can be effective in re-angling that screw access hole so that we can, in fact, get the screw access hole within the envelope of the tooth that we're replacing. So it's one thing to have a tilted implant, it's another thing to be able to match it with the prosthetic components for whatever case that you happen to be using, the restoration, whatever the manufacturer, of course, has the right components. And so we have the technology to be able to do this, to be able to zoom in, to be able to appreciate. And I'd like you to pay attention to some of these implant placements, and you can see the multi-unit abutments here. And you can visualize, in this case, in the left-hand screen, that there is an emergence for these multi-unit abutments to re-angle, and therefore we have to make sure that they're not impinging on either soft tissue or bone. We can also use third-party software that's free. This is a program called Mesh Mixer, and it allows you to edit in 3D objects and create STL files or standard triangulation or tessellation files to be able to import into your Cone Beam CT or export for CAD CAM or 3D printing purposes. So it's really important that we have an understanding and utilize selective transparency. And in this case, what we did was we printed actually in a 3D printer an analog model so that we could in fact control the temporization. So if you want to do immediate place and immediate temporization, you could actually go back to the analog days, utilizing a digital workflow, come up with a CAD CAM designed prosthesis, but not print it. We could use a vacuum form matrix and be able to then come up with an acrylic transitional restoration. So merging of the technologies becomes important. This is where the STL file has to be merged with the Cone Beam CT information and the 3D reconstructed view, because we know that the surface morphology represented in the cone beam is not as good as the surface morphology based upon a study cast, a stone model, or an intraoral optical scan. And now you can see the importance of selective transparency to be able to visualize each one of these objects in relationship to each other, especially in this case, the close proximity of the natural tooth roots and the proposed position of an implant. And so we can go to many different lengths to be able to simulate the position of implants within the bone, but that's not enough. We have to use our proper segmentation to get these clean models. We want to be able to merge them with our intraoral scan or a stone cast, as you see here, and we're going to take that information and merge it with the Cone Beam CT data. That is really the goal that we have in terms of managing our digital workflow. And so now we have true restorative planning, but what's missing? What's missing, of course, is the teeth. So we need to have either a diagnostic wax-up or we create a virtual tooth setup. And we can do that in various software applications that exist today, which allow us then to be able to position the implants. And now you see those yellow projections above the occlusal table, and so allowing us to be able to get the implants through the central envelope of the teeth, if that's the desired position, for either screw retained or cementable. And so we can manage the implant position, we can tweak that implant position, and we can visualize selective transparency to be able to achieve the results that we would like to achieve, as you can see in this particular example. So when we're dealing with different implants, different components, different abutments, we have to be able to understand that there are a lot of parts and there are a lot of pieces. And so we're not just looking at implant stability, we're also looking at the stability of the abutments. And how do you choose to load an implant or not load an implant? And again, here you have two side-by-side implants, and we have to be able to visualize and objectively measure implant stability with resonance frequency analysis and get an ISQ value. However, the concept of guided surgery, in my opinion, as I always say, if you put two dentists in a room, you're going to get at least 3 different opinions. So there's a lack of agreement on where to place an implant in a particular receptor site. And here's an article that was also published in Dental Tribune International on brain guided concepts. And so we can print 3D models of the mandible, we can print 3D models of the maxilla, we can have this in our hands. And here's where we can really maximize some of the concepts where we can do not only placement of the implant, but utilizing bone reduction. And this is what we do in some of our hands-on workshops. And you can see the different parts and pieces. And this is called Chrome Guide. And you can visualize the different parts and pieces here. This is a tooth-borne guide that fits over the existing teeth. We position this. We create a flap design and reflection. We fixate the pin guide, and then this part is removed, leaving the teeth in place. So now, with the pin guide in place, we will go back, we will remove the teeth, we will do bone reduction, and then from there we will be able to have a nice, clean, flat surface, and we're going to then place the restorative result, the temporary prosthesis, and make sure that that snaps in and allows us to be able to go from implant placement to restorative placement, again, accurately seating on a stackable guide. So here you can see that we have a clear guide that fits over into the Swiss locks that allows us to make sure that the bone reduction has been adequate. And you notice the holes are for the placement of the multi-unit abutments. We're going to verify the bite. We're going to then make sure that we use our drilling sequence properly, position the implants, and this will be immediate extraction, bone reduction, immediate implant placement, and immediate loading, similar to the Tremblay article that I showed you earlier. Now, here's another wonderful advance where we're going to now, instead of doing a lot of bone reduction, what if we don't want to do a lot of bone reduction? What if we don't need to do a lot of bone reduction? Perhaps we can do a scalloped approach, and Maurice Salama has recently published an article on this concept. And again, these are concepts that we've been tinkering around with for many, many years. And this is a scallop guide, which operates on the exact same principle that we talked about before. And in this case, we're going to go in and we're going to, hopefully if this video works, we're going to utilize the scallop guide, again, snapping into the pin guide to be able, in the foundation guide, to be able to then adjust, in this case, the teeth and the bone to be able to be in a scallop type position. So you can see here that there is a different approach depending upon the actual diagnosis, treatment plan, and the guided outcome that you want. So we're going to utilize a root membrane concept in this case and actually do root membranes across the board. And this is a wonderful case by my partner, Dr. Isaac Towell, in our educational institute. We can see the different components here for the scallop guide, and then placing the implants through the scallop guide. As you can see here, one by one by one, controlling the trajectory, controlling the depth, and you'll notice that there are root membranes on each one of these anterior teeth. And so the implants will go in, will be torqued to the final position, as you can see here. So this is a guided approach to the root membrane concept. Really quite innovative with a scallop guide to adjust the level of bone. And then, of course, we're going to place the multi-unit abutments, as you can see here, placing rubber dams. And then we're going to, again, utilizing the Swiss locks, put the prosthesis, snap it into place, and then inject our light cured acrylic. And you can see, or dual cure acrylic, and you can see that we're picking up the prosthesis. So it's not just about guided surgery, it's about guided restoration. And as you can see, here are all the parts and pieces. You can visualize the multi-unit abutments, and there you can see the root membranes for each of these anterior teeth. So we are constantly evolving. We're constantly trying to push the envelope, and here you can see the temporary prosthesis in place. We like to use the Megatorque instrument, which is a very handy tool to be able to drive the screws in place, especially in hard-to-reach areas. And here you can see the immediate post-op result for this particular patient. So this is an FP1 type of prosthesis. In many cases, this is really what we want to see. And this is about 2 weeks post-op. You can see the soft tissue is just managing itself very well with the interproximal papilla, and this will be a case that hopefully we will be publishing in the near future when we are completed with it. As you can see, multi-unit abutments, again, we have to be able to have good stability, not only of the implants, but the abutments, and we also have to have good soft tissue stability. And so as we start to visualize each one of these cases, as we start to look at the planning aspect, we also have to, of course, plan the soft tissue outcomes as well. So we want implant stability, abutment stability, and soft tissue stability. And this is something that we can achieve with proper planning. So we can visualize here multi-unit abutments. And here's, some of the multi-unit abutment concepts here, the different 17 and 30 degree angles. And you can see that there is definitely a ledge. And if you haven't reduced the bone properly around the implant itself, you can see how the multi-unit abutment could potentially interfere with the seating if it is impinging upon bone or soft tissue. So here's our bone profiler kit. This is from AnyRidge. And it's not ours, it happens to be available. And most companies make something like that to be able to profile the bone surrounding the implant so that you can seat these angled multi-unit abutments to re-angle the screw access hole within the envelope of the teeth. And hopefully we will have nice contours of the soft tissue, nice emergence profile for the restoration. And of course today, one of the big, concepts is to be able to use monolithic zirconia restorations. So we're milling this with a one-piece restoration, CAD/CAM, of course, designed and milled and beautifully stained. And so, of course, when you have a lot of bone reduction, you're going to need pink. And of course, that is something that you may need for many, many cases. And in other cases, you may not need as much pink, like we just showed an FP1 type of prosthesis. And so this, again, should be discussed with the patient. Now, many times we need that restorative space to be able to bring the patient back to normal function, as well as aesthetics and the proper jaw position. So in this particular case that I just showed, this is a monolithic zirconia result in an FP1 type of prosthesis, meaning that there is no pink, and we can emerge out of the soft tissue just like any natural tooth would, with a screw-retained restoration with monolithic zirconia. So these are, again, are some of the solutions that we have that that ability to be able to visualize and to be able to emerge properly and to be able to have the cosmetic result that we want to achieve. But before we actually go to the monolithic zirconia, we're going to have a resin prototype that, again, will be 3D printed or maybe a CAD/CAM potentially. And you can see the gold bases, the gold copings, and we're going to try this in this particular case was done by R2 Digital Laboratory in New Jersey. And the emergence profile can be evaluated, and you want to be able to evaluate the bite, you want to be able to evaluate the emergence profile, the embrasure designs, etc., before you invest in the entire process of a CAD/CAM restoration. So when we have a restoration that meets the specifications that our patients desire in both function and aesthetics, then we've met all of the qualifications that we need. Let's go back to this for a second, because I just wanted to make sure that we show some of the CAD/CAM design process that goes on. Once we've done an intraoral optical impression, or we've done a scan of the working cast, of course the laboratory is going to fabricate this restoration based upon the parameters of the placement of the implants and the desired occlusion, both function and aesthetics. And so when we have the ability to be able to plan this in terms of the CAD/CAM design, even before the implants are placed, that to me is the most ideal situation. And we are certainly at that stage today where we're able to do that. And so having the ability to be able to pre-plan all of the positions of the implant and be able to then create a PMMA or any kind of other resin template, and then finally mill it in monolithic zirconia, we have the best of all worlds. And but what's important is to manage the screw access holes so that they don't come out within the embrasure, ideally so that they come out within a healthy amount of material so that we avoid fracture. Nothing in this world, of course, is foolproof, but we have to make sure that we position the implants where the teeth need to go, restoratively driven implant dentistry. And so here's our monolithic zirconia, and we can visualize where the screw access holes are coming out within the body of the teeth, and here's the emergence profile in an FP1 type of prosthesis. So you can see that we do have, in fact, a very nice emergence profile, and for this particular patient, the patient was very, very happy with this type of result. Here's the postoperative panoramic radiogram. So as we can see from the postoperative presentation, the implants are parallel, and we have basically almost no cantilever, just a small cantilever on the posterior left side. And the patient was so pleased with that, our next step is to do the lower, of course, and match the occlusion. So we are managing to be able to combine technologies to enhance our treatment outcomes for our patients. So I'd like to leave you with a couple of final thoughts based upon our short hour that we're trying to spend together tonight. And again, I appreciate everyone taking the time from your practice and from your family to be able to spend some time with us during this webinar. So some final thoughts. Cone beam CT, by far, is the foundation for proper diagnosis and treatment planning. That is the tool that we can't live without in terms of preoperative planning. We are combining cone beam CT data with digital and optical scanning, which aids in planning accuracy. That is really, really important today. It's important to be able to create a diagnostic wax-up, whether it's virtual or real, and have that scanned and merge it with the cone beam CT data so that the implants are placed in the proper position. I think we know after at least 10 years or more of published research that the root membrane or partial extraction therapy is a proven surgical methodology. We're doing more and more of those cases, and you will see more and more of those articles coming out. You'll see multi-center studies coming out as well, and it's very important that that diagnosis is important for any one of these procedures, even partial extraction therapy, root membrane concept. So we're using 3D printing. Not only is it an excellent tool for creating our surgical guides, but it's a tool, it's an excellent planning aid because we can print a mandible or a maxilla in advance of the procedure, and we're able to hold the mandible or maxilla in our hand, especially when we're doing sinus augmentation procedures or other more complicated procedures, like as you've seen with the chrome guide and stackable guides. We really always will print a 3D model of whichever arch we're working on. Immediate loading is absolutely an accepted treatment modality. We're doing this on a regular basis. I've been doing immediate extraction, immediate placement since 1989, and immediate loading is about 85% to 90% of what I do with implant dentistry on a daily basis. And so it is here to stay, and of course it is an important part of our ability to treat our patients better, because obviously patients really want to get ahead in terms of time, and some of these procedures obviously have taken a long time to complete with implant restoration. New template designs, like you saw, the scallop design, the stackable designs, and many others. We use 3D printing to create sinus augmentation guides, sinus lift guides, bone harvesting guides. All different types of guides are being created now. And there's so many innovative people that are out there that are doing this technology on a regular basis. Of course, more education and training is needed. And that's really where we are today with some of the technology that we're presenting. And many of this is we're utilizing in our live surgery courses. And we do this in many different locations. We couldn't do a lot of what we do, of course, without industry partners. When we're doing bone grafting, when we're using membranes, when we're using our surgical instruments, of course, the implant placement, and of course, tonight, our sponsor for this webinar was IDS, Integrated Dental Systems, which is the exclusive distributor for the AnyRidge MegaGen implant system in the United States. My partner and dear friend, Dr. Isaac Towell, co-director of Advanced Implant Education, and here we are, of course, in front of the computer looking at a cone beam CT planning for a case that we are going to be doing with one of our student clinicians. And so everything is based upon a proper 3D evaluation for every single patient that we work on. So thank you to IDS, Integrated Dental Systems, greatly appreciate it. And here's a little clip of one of our programs that we did in Tijuana, and you can see we just had a sold out course in October. Our course next week, well, actually this week, I'm sorry, on Thursday, we'll be heading back down to San Diego and then to Tijuana for our next program with Dr. Isaac Towell and all the wonderful staff and faculty, and we're very fortunate those courses are sold out. February is almost sold out, and we do have some spots, I think, for February and April of 2019. So we design these courses for the novice, for the intermediate, for the advanced. If you've never placed an implant, if you've never done a sinus augmentation, if you've never done ridge splitting, we have one of the best faculty-student ratios. It's a 1-to-1 ratio, so every chair has a faculty, and whether you have a single chair that is just yourself, or you're sharing it with another clinician, we can bring in cases of the level that fits and tailored to your desire for what you want to learn and be trained in, whether it's soft tissue management and transcrestal sinus augmentation, lateral sinus augmentation. You can see Dr. Towell at work there. Everything is planned on cone beam CT. Everything is important that we have proper diagnosis and treatment planning. So again, that's Advanced Implant Education. It's been my pleasure to be able to join you tonight from people from around the world. I greatly appreciate the opportunity, and I will be happy to answer some questions that people have written into. I see one question about doing a socket shield bone graft, if the patient is not ready to do an immediate implant, but maybe wants to do one in the future. And certainly you're always available to be able to do a bone graft, an immediate extraction and bone graft, and place an implant at a later time. That is certainly something that you can do. Bone reduction templates is something, again, that is going to be designed by the people that you're working with, whether it's a dental laboratory or some of the third-party companies that are helping you with planning these cases. It's very important that you work with competent people, and there are many of them around that can create and help you plan cases. You don't have to go out and buy the software. You don't have to buy expensive equipment. There's plenty that's available from all over, anywhere in the world that you happen to be practicing. And so some people that were asking how do you contact me, my email address is Dr. Ganz at drgans.com. I showed that on the very first slide. You can see that here in the lower right-hand corner. It's Dr. Ganz at drgans.com. It's really, I try my best to answer any emails. So, and we're certainly happy to answer any questions about our live surgery courses or any didactic courses that may be coming up for the remainder of the year. Dr. Towell and I will be doing workshops at the Greater New York meeting. We'll also be able to do a workshop, hands-on workshop at the Meisinger High Altitude Comprehensive Implant Symposium, which is now, I think, in its 9th year. And I'm very proud of that meeting. We've done it's a tremendous meeting each year, and that's in Vail, Colorado. And then we have, again, our live surgery courses that are being held in February and April of 2019, with other dates that will be available on our website, aiedental.com. So thank you so much for your kind attention. It's really been a pleasure to address all of you. Have a wonderful evening, and let's see, for those of us that are in the U.S., let's see how what the election results are. Regards to everyone.